Hello, and welcome to the UK NEQAS IIA webinar series, Mysteries of Myeloma. I'm Liam Whitby, the President of UK NEQAS, and I'm proud to introduce today's webinar session, Diagnostic Testing for Myeloma, Challenges and Pitfalls, Part 1. Now, I'm sure you're all very familiar with Zoom by now, but I'll take you through a few housekeeping rules so that we're all aware of how this webinar will be formatted. Now, our speaker will present her slides, followed by approximately a 15-minute question and answer session with our speaker panel. Now, all questions can be viewed by attendees here today, and you can also submit, you can vote on the questions, and if you think a question is really important and you really want it answering, please feel free to upvote it by clicking on the thumbs up icon next to the question. The more a question is upvoted, the more likely it will be to be asked, because we'll just work our way through the most popular going downwards. Now, we won't be using the chat function to answer questions, and I would ask that you don't raise your virtual hands. Now, we are recording this webinar, and we will be sending links to the on-demand recording to all of the registered delegates in the next few weeks so that you can review and revisit any points that you really want to focus upon. Now, sadly, it isn't possible for us to award CPD points as we can't verify attendance on the webinar, but we will send registration certificates to you all via email. If you do want to use this webinar for CPD purposes, we suggest that you write a brief reflective statement on what you have learned from the session. Now, I will say that we have just done our pre-webinar checks, and there is a little bit of background noise on the channel. We are aware of it, but there's nothing we can do. So we do apologise for that, but it shouldn't impinge on your enjoyment and the overall experience. So without further ado, I'm delighted to introduce our speaker today, Dr. Joanna Sheldon. Jo has worked in the protein reference unit for about 40 years, from being a trainee biomedical scientist at the bench to being consultant and PRU director. Jo has always liked the hands-on aspects of the protein laboratory, and it has considerable experience of manual immunoassay, electrophoresis and immunofixation. Teaching and training is an integral part of the PRU, and many of you will know Jo from seminars or scientific meetings on proteins and immunology. Jo, if you're able to turn on your camera and your microphone and share your slides with us, then I will hand over to you.
Fantastic. Okay, can you all hear me? Well, not that, can the people who can communicate with me hear me?
I can hear you. Yes, I can hear you.
Fantastic. Perfect then. Okay, let me share my screen and see where we go. Well, it's again. I had a brief little time with you last week where we heard that absolutely fantastic talk from the patient Mark and Fenella Willis, one of the consultant haematologists, about really the journey that a patient has to the first symptoms of myeloma right through to diagnosis and treatment. And I'm sure many of you who don't have a lot of patient contact will realise just how devastating a disease it can be, particularly if it isn't diagnosed quickly and managed appropriately. And I think whenever we think about myeloma, we have to bear that in mind, because every sample that we get in the lab is actually a sample from a patient. I know that's a slightly glib thing to say, but it's the truth. It's one of the important areas where we actually have a very direct impact on the patient and the patient's care. And that leads me on to, why do we need a webinar? Well, as you heard last week from Mark and from Fenella, patients are at the centre of what we do, and every single thing that we do in the lab, we have to bear in mind that the importance of the patient and doing the best for the patient. And we need a webinar because it's possible that we're not always doing the best. Let me see if I can just click down to the next slide. So we heard from Mark about the delay. We heard that he had 3 GP visits, 2 physio visits, 2 A&E visits, 1 visit to an osteopath. And this all happened over about 7 months from his first symptoms that could have been attributed to myeloma until the diagnosis. He described his complete immobility due to the unwavering pain and his inability to work. All of these symptoms were life-changing. And it would be lovely if we thought, well, it's a one-off, but actually that isn't the case. About 40% of patients have a significant diagnostic delay, and the diagnostic pathway for myeloma, as we heard from Fenella Willis, is about 163 days. And if you bear that, if you think about it, if any of us experienced pain today, symptoms today that could be attributed to myeloma, most of us wouldn't expect a diagnosis until the 8th of October. And that's the reality of the kind of time frame that patients are waiting. A few years ago, we did a survey and we saw that the turnaround times for electrophoresis and paraproteins were, some people were reporting 15 minutes, which I think is a little bit of a strange answer, but most people were saying, 2 to 3 days. And yet, when we talk to haematologists, we say, how quickly do you get a new paraprotein round, or how quickly do you get a paraprotein follow-up around? And they're talking about weeks rather than days. So what we're doing in the lab doesn't seem to be entirely consistent with what the haematologists are feeling, and it's certainly not in line with what we would expect for a patient. Let me just get the next slide. So does the delay matter? So aside from the significant physical and psychological symptoms, the impact on the patients, the impact on their lives, their work, their families, if there is a diagnostic delay, and again, I'm repeating what Fenella said, but it is important, 20% of myeloma patients die within 60 days of diagnosis. So if there is a delay, that delay is causing significant symptoms and possibly even leading to their early death. And 20% of myeloma patients is greater than 1,000 patients a year. 32% of patients diagnosed through an emergency route. So it takes patients to come to A&E with significant symptoms, with crippling bone pain, with hypercalcemia, with anemia so low that they need to be admitted for a transfusion. 32% patients come through that emergency route. And if they come through the emergency route, their survival is significantly worse. So we can talk about these delays, and we heard about them last week, and we've reinforced the importance of the presence of those delays. So where do those delays come from? So this is a slide that many of you will have seen before. So up here we have the turnaround times, the pre-laboratory time, the laboratory turnaround time. This is the bit that we're most interested in. This is the bit that we can monitor, that we can do something about, that we feel we can manage. And then this area where the results are put onto the computer, but not very often phoned through to the requesting clinician. So these areas are times where, well, all of these areas are times where a delay can occur. Now, there are difficulties here because, as Fenella explained, the presentation of patients with myeloma can be very complex, and they can be often perceived as being other things. I mean, anemia isn't a symptom or isn't a finding that's particular to patients with myeloma. Back pain is a very common symptom that people go to their GPs with. So there's that delay because of the complex presentations, the slightly clouded thinking, which patients, what tests, I'm not too sure. Then the lab doesn't help because we're a little bit fuzzy about what we're doing. We're doing immunoglobulins and electrophoresis, and we know that actually the sensible reasons to do it is if you're thinking of B-cell malignancy or immune deficiency, and occasionally an autoimmune liver disease. And we know that we would think of immunoglobulins for things like raised calcium renal impairment, anemia, bone pain. But actually, we have this enormous set of requests that for all sorts of crazy reasons, and I've never had a better request for immunoglobulins than fell off a bar stool. I mean, how that can relate to immunoglobulin investigations, I have no idea, but that remains over many years my favourite request for immunoglobulins. We also have this difference in opinion. Which tests should we be doing? Should we be doing urine or serum-free light chains? And we touched on those questions a little bit last week. What techniques to use? Some guidelines say you should use nephelometry, some say you should use turbidimetry, some say it doesn't matter. There's also limited training, and I think increasingly the electrophoresis immunoglobulin type service is being considered a little bit sort of low level. It doesn't need senior people to look at it and oversee it and report it. And in fact, again, from that questionnaire a few years ago, we were shocked to see that people at band 2 who aren't even HCPC registered were reading electrophoresis. And that seemed to be an extraordinary situation where the reading of that electrophoresis has been or downgraded to a level where you don't even need HCPC registration to look at the sample. And there's no guidance on turnaround times, what's the best practice for laboratories, what the best way to communicate results is. And yet we've got loads of different guidelines, but they really relate to patients when you've got a high index of suspicion, when you've got at least probably one finding that makes you think of myeloma. And it's that next step to say, how am I going to diagnose myeloma in this patient, rather than thinking of what we see in the lab, which is sort of immunoglobulin all comers. So all of these people, all of these requests here. So if I go on to the next slide. Okay, so where do the delays come from? Again, Fenella Willis said GPs probably see an average new myeloma case once every 3 years. So there's a relatively low awareness of myeloma. We've spoken about the complex presentations and about the non-specific symptoms. And GPs, if you think about how much information GPs have to hold and regurgitate and manage for their multitude of patients, actually they don't have necessarily a very high understanding of the immunoglobulins, electrophoresis, free light chain type testing. And that leads to a poor understanding of exactly which tests to request. So there are two issues here. They don't have a very high awareness of myeloma because it's not a particularly common disease and they won't see it very often. And also they don't have a very acute way of asking for the right tests. Oh, this is going to drive me slightly mad. But we could say, well, this is not our problem. This is GPs, this is GP training. This has nothing to do with the lab. This is before we even get involved. And that's how it should stay. But actually, is that the case? Because the lab should be experts in when, why, how to do the tests that we offer. And if you all look around the rooms that you're in, and I'm sure as we were coming online, I saw that there were about 350 registered delegates. If you look around the room that you're in, because I'm sure there's more than one person in each room, or many rooms where you're watching this webinar, have a look and see how many senior members of staff there are. How many people who would possibly go out and do a GP education day? How many of those sorts of senior people are in the lab? Or has this webinar been focused on people actually in the lab at the bench? Because it's those people who go out to do GP education sessions that are the people that can help guide the GPs into the right sort of thought process for considering myeloma. And actually, when a significant proportion of immunoglobulins and electrophoresis is now done within clinical biochemistry, think about how many GP education sessions you've done about, the over requesting of vitamin D. I'm sure that's very high on everybody's list, or diabetes, or the investigation of thyroid disease. How many have your senior colleagues done for GPs in their education days or weeks on the investigation of B-cell malignancy? And has your lab got requesting guidelines for immunoglobulins and electrophoresis? And I think they're important questions to ask, because we can't really sit back and say, oh, it's not our problem. This is GP land, it's not us. It actually is us, because we're ideally placed to do this. Part of the issue is that GPs aren't aware of it. And last year with Fenella and the Myeloma UK, which is also sponsoring this webinar session, and hopefully there are a number of people from Myeloma UK who are interacting or on this webinar. With Myeloma UK, we decided that we wanted to write a myeloma diagnostic tool for primary care. We wanted it to be very, very straightforward and simple, covering the highlight points. And so this is the sort of the whole thing, and I'll go through each little section on its own. But if you want these, you can get them from Myeloma UK. You can download them from Myeloma UK. And I have to say, I had a large part in writing it with Fenella, but I think it's really helpful, and we've had fantastic feedback from GPs who said it's incredibly useful. So if I just whiz through it, so obviously there's the preamble, what it is, things about paraproteins, free light chains, multiple signs and symptoms, etc. So that's just sort of the preamble to introduce it. And then we say when to test. When should a GP start thinking about myeloma as a possible diagnosis? So we all know about the CRAB criteria, a raised calcium, renal impairment, anemia. We've also got bone pain in there, raised ESR, and then those sorts of maybe slightly woolly symptoms, generally unwell, recurrent infections, breathlessness, all things that could be seen with other conditions. But then the important factors is if those symptoms persist without any explanation and despite interventions, and then the red flags, things that include unexplained symptoms and more than one symptom. So something really simple like this, that's just not even a side of A4, it makes the GP very able to have a look at that and think, oh yes, yeah, I can't explain why the patient's hypercalcemic, or they've got renal impairment, or they're anemic. I better think of myeloma. And so that fits in quite nicely with what we're saying here. And of course, immune deficiency in adults can be one of the findings that you would see in myeloma. And for example, light chain only myeloma. So immune deficiency can feed back in adults into B-cell malignancy. Then what tests to do? And this is where there's a lot of discussion, and I'm sure there will be a lot of discussion. I think undoubtedly serum protein electrophoresis, looking for a paraprotein, serum immunoglobulins to go along with the electrophoresis, and then serum free light chain assay and Bence-Jones protein. Now, I don't necessarily think they're interchangeable, and I think they have to be used very carefully. And those of you who know me that know that I'm not a great fan of serum free light chains, unless there's a particular and carefully thought out reason. But certainly serum-free light chains have to be in the mix because they're important tests in patients with myeloma and other B-cell malignancies. Obviously full blood count, serum calcium, serum creatinine to look for renal impairment. So they would be the kind of tests that should be requested. And then the very important part is, what do we do with the results? Because the results can kind of go into the ether. If the GPs, if they do a large number of blood tests on a significant number of patients, obviously they're going to get a large number of results back. And filtering through those results can be extremely time consuming and can be quite challenging. So we've listed this into, you know, the red signs, the amber signs and the green signs. I think that everybody seems to be going with traffic lights at the moment. But what we're saying here, any paraprotein or abnormal serum free light chain with significant symptoms suggestive of spinal cord injury or acute kidney injury, you need an urgent referral to clinical haematology. If you have a moderate concentration of paraprotein or an IgD or an IgE paraprotein or an abnormal serum free light chain or Bence-Jones protein, a 2-week referral to clinical haematology. And then this group in the middle, this amber group, is probably going to be quite a large group because these are going to be minor concentrations of paraproteins, and we've given the concentrations there, with a minor abnormality in the serum free light chain ratio. This is a pattern that we commonly see in the elderly patients. And elderly patients, and I've said this many times, you know, as I'm getting older, I realise I'm getting to the sort of elderly stage, and that's not a very comfortable thing to find. But actually we do have to think that as people do get older, they do get more paraproteins, and these would be probably the MGUSs, and you're going to hear more about how we manage it, how we're monitoring MGUS patients in the lab in 2 weeks' time. But there we're saying check the electrophoresis, check the urine in a couple of months to confirm the pattern and assess any progression. Of course, you can also see that pattern, for example, in infections, and we've seen these kinds of small paraproteins associated with COVID infections. So they're commonly seen in patients with infections. But patients whose paraprotein concentrations increase, so either greater than 25% or greater than 5 grams per litre over 2 to 3 months, or develop symptoms, they need to be referred under the 2-week rule. And of course, if you're concerned about, if the GP is concerned about the patient, they should discuss with clinical haematology. And here we have the last group. So no paraprotein, normal free light chain ratio, no Bence-Jones protein, normal immunoglobulins. Myeloma is unlikely, but of course, the symptoms still need to be considered. It may be other B-cell malignancies, it may be other conditions, but myeloma is not 100% excluded, but pretty much excluded. So that diagnostic tool is an incredibly useful and simple way of GPs to access the information of when to request and what to do with the results. So what should we do? So we've got that fantastic myeloma diagnostic tool. What suggestions can I make? Well, senior staff need to engage with GPs on when, why, how to request paraproteins. And we also need to engage with the haematologist, because the lab doing the paraprotein investigations is often the link between the GPs in primary care and the haematologists who are ultimately going to manage the patients. We also want to have an agreed testing set for myeloma. And I would suggest that people reference the GP diagnostic tool on your reports for immunoglobulins and electrophoresis, because it will undoubtedly help GPs look at those results and understand them. So actually, the next question I asked was, why is the lab so important? And I know that, I've sort of semi-retired, so I haven't been involved in the lab, but during COVID, I thought how we weren't kind of on the front line. And I'm sure some people felt that they weren't really sort of quite doing enough because we weren't involved in managing those critically ill patients. But actually, this sort of area is an area where the lab has an absolutely integral role. And why is that? Well, if you think of the diagnostic criteria that we spoke with, that Fenella spoke to us about, she spoke about the abnormal number of plasma cells in the bone marrow. Now for that, a patient needs to have an appointment and they need to attend hospital and have this procedure that has to be done by a clinical hematologist, for example. Or they have to go for an MRI, which means the patient needs to make an appointment, go to the hospital, have this procedure. Or they can do electrophoresis and immunoglobulin with urine with free light chains. So it's done by GPs or phlebotomies. It's not limited by MRI time. It's not limited by hematology time. So that simple investigation is often the very starting process in all the follow-on tests that you would use to make the diagnosis of myeloma. And I know, and you know, it makes you feel a bit kind of proud when you go along to hematology or phone a GP and say, we found this big paraprotein in one of your patients. Sometimes the GP says, oh my God, I didn't have any idea. That's amazing. Thank you so much. And actually it makes a difference to patients. And that's why I think it's one of the areas where we in the lab can actually have that big impact on a patient's care by going along, not just doing the tests, but going along and telling people what the results are. And I think that's probably one of the reasons I quite like the protein service, because we have an impact and it's a noticeable, obvious impact. And then on to guidelines. Now, I know these are kind of guidelines, but when you're talking about myeloma guidelines, there is loads of them. This is just a little snapshot of them. And they're all very much focused on confirming that diagnosis and managing the patient. They are not related to the other conditions that are associated with paraproteinemias, for example, Waldenstrom's, macroglobulinemia, lymphoma, CLL, amyloidosis, MGUS. So the focus of those guidelines is on myeloma, and yet what we see in the lab is quite different. So the myeloma guidelines are focused on the hematology patients, the hematologists, what you need to make that diagnosis in a patient with a high index of suspicion. And as Fenella said, there's about 5,700 new myeloma patients per year. But there aren't any real guidelines for the lab aspects. And when we looked at the survey in 2017, we found 75% of labs are doing about over 1,000 electrophoresis per week. And certainly the couple of labs that I'm involved in, 1,000 electrophoresis per week. We also found that about 36% of requests for immunoglobulins and electrophoresis are sensible. So they're considering B-cell malignancy or immune deficiency. On the clinical details, they may say, you know, raised calcium, poor renal function, anemia. 64% of those no flipping clues, you know, like, I don't know what I'm going to do, let's check the immunoglobulins just in case, for things like, you know, bar stool and connective tissue disease or SLE or hearing loss or personality change. So there's what we see in the lab is not what the myeloma guidelines are heading towards. And in a sort of a pictorial example, those blue ones are what we're doing every day, so about 200 electrophoreses per day, and yet about 36% of them are only sensible requests for myeloma immune deficiency. So there's a lot of other stuff that we're doing that we may pick up the odd paraprotein in those, but actually the clinician hasn't necessarily thought of that at the outset. So back to those relevant details. If we're thinking of immunoglobulins, electrophoresis, urine BJP, serum free light chains, these are the kind of symptoms that we would expect to be looking. And they're quite a broad brush. Anemia, unexplained renal failure, back pain or bone pain, hypercalcemia, raised ESR or raised plasma viscosity, lethargy, night sweats, hyperviscosity on there twice, and then for immune deficiency, unexplained severe infections, atypical infections, prolonged infections, frequent infections. And as I said before, that immune deficiency also feeds in to the B-cell malignancy stream. So what should the lab do? We've said we probably, well, we should have an agreed test set for query myeloma. We have these incredibly sophisticated lab computers, but I wonder if the lab computers are driving us rather than us driving them. What we really need is some sort of, for example, pop-up to say immunoglobulin request. Is this for diagnosis or monitoring of B-cell malignancy or immune deficiency? Reminding people of the reasons to do it. Or we could replace immunoglobulins and electrophoresis with, for example, a test request that could say myeloma diagnosis, myeloma monitoring, immune deficiency diagnosis, immune deficiency monitoring. And then, along with the haematologists, agree which tests are included in each panel. Because I know some labs will have a broader selection of tests routinely available than others. So you do have to agree what tests you're going to be using. And then I think we probably should, we can divvy it up in many ways, but this would be my suggested way of dividing it up. So we're looking at first line testing. I would suggest first line testing immunoglobulins IgG, A and M, and serum protein electrophoresis, and urine total protein concentration and electrophoresis. And we can discuss the value of urines. I mean, I still believe in them and we still have competence in them. But I know some labs have lost that skill and therefore don't like doing urines, and their serum-free light chain seems to be a suitable alternative. And interestingly, after 9/11, the Mayo Clinic, which has been a great proponent of serum-free light chains, after 9/11, they had a huge problem with getting urines because a lot of the patients going to the Mayo Clinic myeloma service came in by plane because they're from a huge area of the US, and nobody could carry a litre or 2 litres of urine, and so they couldn't get urine samples from their patients. So it was important that they had an alternative, and serum-free light chains became that alternative. But of course, those patients are possibly a little bit further on in that myeloma diagnostic pathway than we're seeing routinely. And then second line investigation would be immunofixation if a new paraprotein is seen, serum total protein and paraprotein quantification. And then the third line testing would be serum-free light chains, and they would be used if there's a high clinical index of suspicion of myeloma or if requested by haematology. And we do serum-free light chains on the request of the haematologists rather than just on anybody who requests them. And of course, there's also serum beta-2 microglobulin, that's the single most powerful prognostic indicator in myeloma. So let's have a little bit of thinking about the first line testing. Now, I know lots of labs don't link electrophoresis and immunoglobulins. And I really struggle with that, because when I think of all of my experience at reading electrophoresis, I'm still surprised when I read an electrophoresis and I see the immunoglobulins. And I'm still surprised when I see the immunoglobulins and read the electrophoresis. And in my opinion, the two have to be done together to appropriately interpret the electrophoresis and immunoglobulins. You need the two things together. And I think we should think about what we're trying to do. And a lot of people have dropped doing them both together because it's saving money. But actually, we would probably save money better by stopping doing the duplicate requests or the inappropriate requests and do the sensible ones properly. So do it once, do it properly. And I think we should also do the urine electrophoresis if we get the sample. An absolute requirement: participate in UK NEQAS in the monoclonal scheme or the specific protein scheme, or a comparable ISO accredited EQA program. Now, this is a UK seminar, a UK NEQAS webinar session, and I think they've been incredibly proactive in giving a diverse set of samples and also doing the educational thing. So I can only support UK NEQAS, but I'm sure there are other providers of EQA schemes. I'm not sure whether they're as good as or as forward thinking as UK NEQAS, but you need to be in an EQA scheme. And it's not just being in the EQA scheme, it's having good continual analytical interpretive performance in those schemes. Your lab should also be accredited to ISO 15189 with UCAS or a comparable accreditation organisation. You need adequate turnaround times to adequate workload to maintain the experience and the turnaround times. So in that 2017 survey, we found that 25% of labs were doing less than 100 electrophoresis per week, and that's less than 20 a day. I would suggest that was inadequate for training and experience. And the other thing that we seem to have pushed towards capillary zone electrophoresis, which is fantastic. But one of the things about CZE is it needs a lot of samples to keep those capillaries conditioned and working well. It's not ideal for small workloads. The immunoglobulins, they should be calibrated with respect to CRM470. They need to be run with a good EQA performance and IQC performance. We're looking at CVs certainly below 5% and probably approaching more like 2 to 3% at low, medium and high concentrations. It's absolutely vital that they have a robust antigen excess check. And that's where you add more antigen to the reaction mix rather than just looking at the curve characteristics. And I think some of the faster methods don't do a particularly good antigen excess check, which means that you can get completely the wrong result for a sample with a paraprotein in it. And if you're doing immunoglobulins, you really need to have a system capable of running stat samples, and that's for things like cryoproteins or urgent requests. And they need to show adequate analytical sensitivity. We want immunoglobulins, we really want to be able to measure down below a gram per litre, preferably to about 0.5 grams per litre, although for turbidimetric methods, 1 gram per litre may be more realistic. IgA should be able to measure down to 0.06 grams per litre, and not just for looking at the immune suppression, but that's really for diagnosis of IgA deficiency or exclusion of IgA deficiency in a paediatric population. And IgM concentrations, we should be able to get down to 0.1 gram per litre. I'm always amazed where I see people reporting their immunoglobulins to 3 or 4 decimal places. That's absolutely ridiculous. So generally, I would say report to 1 decimal place for concentrations above 1 gram per litre, and values below 0.1 gram per litre report to 2 decimal places. Provided your analytical system is validated to report to that concentration. And then CZE. CZE is now the method of choice for protein electrophoresis. Most labs in the UK are moving towards CZE. It's interesting because it detects the proteins after they've been separated by UV absorption. And you can use, it comes out as an electrophoretic. I'll show you one in a moment. And you can delimit those protein bands on the screen, and by inputting the total protein, get a paraprotein concentration directly. It's very important to remember that a paraprotein will always run in the same place on the electrophoresis. The same paraprotein will also always have the same monoclonal characteristics of the same amino acid sequence, the same way it's put together, and it will also have the same charge and therefore will always run in the same place. And we use the X coordinates of the CZE to look at this. So if you look here, this is a screenshot of our CZE. And if you look up here, this is the X coordinate, and you can see that we've delimited this paraprotein here. And it's at the X coordinate, the beginning of it is X coordinate 233. And the far end of it is at the X coordinate 246. And if we've got more than one paraprotein or a funny pattern, or we're looking for example, one of the new drugs, something like daratumumab, we can use that X coordinate to highlight where the paraprotein is, and it'll also give us a clue to what it is. Daratumumab runs in a very particular place on the electrophoresis, and so do other monoclonal antibodies. Smoothing. Now, smoothing is one of the characteristics, one of the things you can do to the electrophoresis that smooths out the bumps. And here I've got 4 traces of exactly the same sample. This is where we would run it, where we would read it at St George's with no smoothing, and you can see a little band there, tiny little zone there, and the band pretty much disappears as the amount of smoothing goes up. So you have to optimize how you would run your CZE, but we always use no smoothing. Now, admittedly, that means that we see a lot more tiny bands, but it's worthwhile remembering that the paraprotein concentration at diagnosis does not indicate the disease severity or the prognosis. So you can get, for example, a very small band of retained lambda or retained Bence-Jones protein, a very small IgD paraprotein that has a very severe disease course. you can also have quite large paraproteins that don't have a severe disease course. So finding a paraprotein, the next thing you should do is type it to find out what the type is, and then report it in conjunction with the immunoglobulins, with the urine, with the serum free light chains, and discuss it with the haematologist to say, is this just a little band that's maybe secondary to infection or finding in an elderly patient, or something more sinister? And this is a variable scale. Another feature of the CZE is that you can actually adjust the scale of the electrophoresis. This is again the same sample, and this is shown at a full scale where all of the proteins are pulled up so the albumin is maximized. And you can see you've got quite a different picture in this full scale sample to this variable scale sample. Here we see a low albumin and slightly raised alpha 2. Here you see a normal albumin and a raised alpha 1, alpha 2, and quite marked beta gamma fusion. So I would always suggest use the variable scale, not the full scale. And then Agarose gel. I'm sure some of you are still using Agarose gel. We still use it for things like urines, for cryoproteins, for small samples. And some paraproteins don't behave the same on the Agarose on the CZE. So we use Agarose for unusual samples. I think the optimum length of separation from the albumin to the end of the gamma for Agarose is about 4 centimeters. And I'm not a great fan of these very small gels where you're running multiple samples. I think you can lose resolution. You can certainly detect big paraproteins, no problem, but you can lose resolution, particularly for small paraproteins in these very compressed gels. And the Agarose gels need to be stained to visualize the proteins, and then you scan them densitometrically. And what you hope to use, and most systems would do this, the stain should be linear over this wide range of concentrations. But it's worthwhile remembering that some stains bind preferentially to albumin. And so if you're trying to go between electrophoresis on Agarose and CZE, you'll find slightly different paraprotein concentrations. Because the gel systems, the stain binds preferentially to the albumin, so you get a falsely low paraprotein concentration. But whatever you do, consistency is important. And if you are changing from Agarose to CZE, then bear that in mind as a potential problem. Urine samples that you can concentrate using static systems or centrifugal concentrators. And we're really looking at a molecular exclusion of about 10 kilodaltons, which will ensure that things like beta-2 microglobulin and monoclonal free light chains are retained in the concentrate. And then we would run the concentrated urines on the gel system, or you could run the unconcentrated urines with a sensitive staining system, or even increasing the sensitivity with an immunofixation step. I think urine investigations are important, and they do have a place in the investigation of myeloma, because what you can see on the urine electrophoresis and immunofixation is very clearly whether a light chain is polyclonal or monoclonal. You can also see if there is a leak of the serum paraprotein into the urine from the intact immunoglobulin into the urine. And if that's at a very high concentration, it could suggest significant renal impairment. But you can also see the background urine pattern, whether it's a glomerular proteinuria or a tubular proteinuria, which may also give some indications of the renal impairment. And I think many labs are losing or have lost that skill in the interpretation of urine samples. And I think that's a shame, because I think it's a very valuable test that we do. And then we'll talk briefly about the interpretation of serum electrophoresis patterns. Here's an Agarose gel and a CZE, and you can see that the two things match quite nicely on the sort of the densitometric scan. And you can see the obvious paraprotein bands on the Agarose electrophoresis. But interpretation patterns, whether it's capillary or Agarose, is not a gift. It's something that we have to work at. We have to have experience and training. We have to have a thought process. Does this pattern that I see make sense? And I think one of the important things that we've always had in the PRU is continuity and consistency. So the people running and reading the electrophoresis have been a very, very constant group of people, and usually at high level. So we've usually had band 7s and consultants reading the electrophoresis. And I don't think the frequent staff rotation that we see in big sort of big blood sciences labs are necessarily good for getting that continuity and consistency. And I think it's something that we need to think about. If we're doing that, if we're providing this service, is rotating staff in and out for a week or 2 weeks or 3 weeks, is it adequate? I think interpretation of electrophoresis is and should be a high-level activity, and not something that Band 2s should do. Now, obviously, you can get people who are employed at Band 2 who are incredibly capable of doing it, but they shouldn't be taking the responsibility of reading and interpreting electrophoresis. When I teach, I say, look at every zone. Is it present? Is it the normal shape? Is it the normal size? Is it the normal proportion to everything else? And we also have to remember that a paraprotein can appear anywhere, pretty much from the alpha 1 right down to the post-gamma region of the electrophoresis. So just looking at the gamma and saying no paraprotein detected, I don't think is an adequate service. So here are a few CZE patterns. So we would comment on every zone, whether the albumin was there, whether it was normal, whether the alpha 1 and alpha 2 globulins were normal, which would mean that we would suggest an inflammatory response, whether the albumin was low, whether the gamma was polyclonally raised, maybe you would see that in liver disease, whether there's a big paraprotein band with immune suppression, or whether there's a polyclonal gamma with zoning. They're just some of the patterns that we see. And at this stage, we would select the samples that it needed immunofixation. And immunofixation is an incredibly valuable tool because it improves both the analytical sensitivity and the specificity. So it shows you, because you're putting the paraprotein with a lot more antibody, you're enhancing, you're making that signal much bigger. So it's much easier to see, but you're also making it specific because of the antibodies that you're using. And here on the right-hand side, we've got, this is probably an IgA paraprotein with 3 bands. This is probably an IgA, well, I know this one's an IgA paraprotein. This could easily be an IgG paraprotein. And this one is actually, this is an IgD paraprotein with Bence-Jones protein. And at this stage, we would select the samples that needed a total protein for quantification of the paraprotein. And when we're looking at urines, always find the albumin and transferrin. And the rule that we have is kind of an almost rule, is we fix anything that has more than a trace of albumin. We fixed anything that hasn't been seen, hasn't been fixed before, and we fix anything where there's strong clinical indications or lab indications of anemia, renal failure, etc. So it's urine, I mean, they're very mucky samples, and they're not ideally, successful in getting onto capillary electrophoresis. They need skill to read them, but I think they're still very important to do. And serum total protein, we should be using a BiRep method. It detects the peptide bonds, and it should be comparable between different proteins. Some other dyes preferentially bind albumin or the globulins. Also, samples that are hyperviscous can give falsely low values in automated systems because the aspiration rate is so quick that you're not aspirating adequate sample, not aspirating the correct volume of sample. So always be careful if you've got a hyperviscous sample, you may need to dilute it to get it onto your automated total protein method. You should always confirm the upper limit of the total protein ranges. I mean, certainly I've seen total proteins up to 170 grams per litre. Over 100 grams per litre are regularly seen. So we need to be aware that the method is linear up to those kinds of concentrations. Obviously, you need QC, it needs to be precise. Your QC material generally should be from a third-party supplier, and you need adequate performance in EQA programs. And again, I've seen total proteins reported to 1, 2, or even 3 decimal places. Heaven knows why. Total proteins, serum total proteins report as whole numbers. And then urine total proteins. We're looking at dye binding methods. Pyrogallo red would be a good example, or turbidimetric using trichloroacetic acid or sulfosalicylic acid. Total proteins greater than a gram per litre are regularly seen, and in significant renal loss, you can see concentrations over 10 grams per litre, but even up to 30 or 40 or even 50 odd grams per litre in massive nephrotic syndrome. And you can see that in myeloma. QC should be precise, again, third-party suppliers, EQA performance, and again, how many decimal places are we working to here? We should be doing 1 decimal place, 2, 3, or 4, ridiculous, so 1 decimal place. Other essentials, training programs, competence assessments, concordance assessments, and we need these for the reading, interpretation, reporting of serum, urine, electrophoresis, immunofixation. And we were surprised that, depending on which particular question we asked in 2017, we were looking at somewhere between 20 and 50% of labs have no training program or competence assessment for parts of the electrophoresis paraprotein service. I think that's very poor, and I'm surprised that UCAS haven't picked up on it. This is an interpretive side of the work that we do, and we need these training, competence, concordance assessments. Absolutely, without doubt, we need those. So we've covered quite a lot of ground. We've had a reminder that the patients are at the absolute centre of what we do. And actually the lab has a huge impact in getting these patients to the right place and also getting the GPs to request the right tests on the right patients. Requests to report paraprotein studies have many factors. Although we in the lab can think our turnaround time is about this long, actually the GPs or the haematologists particularly are describing it as sort of this long, much bigger. So there has to be a way that we can improve that. Although we're doing everything we can in the lab, we probably have to have a better way of communicating the results. And the lab is ideally positioned to drive this improvement. I think the GP diagnostic tool has been a phenomenal advantage where we can all use that. Every lab can say, you know, check the GP diagnostic tool if you're considering myeloma, and that will heighten the GP's knowledge and understanding of myeloma. It'll also get them to realise that the labs we're all working together. And I think one of the things that's happened over the last few years is that we've sort of separated the GPs as separate labs. Actually, we're all working together for the patient good. We've spoken about this perspective between guidelines and the lab, and there is quite a dissociation between the two things. The guidelines are important, but they aren't ideally placed to guide the lab. Now, those basic requirements for the protein testing, we've spoken about sort of first-line testing, second-line testing, interpretation of electrophoresis. So we've covered some ground, but of course we've got next week where we're going to talk more about immunofixation, serum-free light chains, things that interfere with electrophoresis, things like daratumumab and isatuximab. Daratumumab and isatuximab, both drugs that are used in treatment of myeloma, monoclonal antibodies that appear on the electrophoresis, and also things like antibiotics and contrast, which can cause big burns on the electrophoresis, but not on the immunofixation. We can also talk about reporting results, cumulative results, and the comments that we make, and maybe give you all some guidance about the kind of things that you should include in the comments and how we can improve the communication of results. So that's me done. Thank you very much, and over to Liam and some questions.
I'm really sorry to sort of say to everybody, I'm afraid that we're out of time so far on this webinar. Many thanks to our speaker today, Dr. Joanna Sheldon, and to Dr. Ross Sadler for joining as one of our panelists. Many thanks to everyone at UK NEQAS. We're making this series of webinars happen. There are a lot of people behind the scenes that make this webinar. I know it looks smooth, but there's a lot of people working very hard behind the scenes to actually make this occur. But particular thanks to everybody taking time to join us today. We hope you found this session both beneficial and enjoyable. Now, this is the second in a series of 5 webinars that we're putting on over the next 5 weeks. You should be able to see on screen now details of the other upcoming sessions, and I would strongly recommend that you book your place on the remaining sessions if you haven't already. In the final webinar, which we've got planned for the 26th of May, we will be joined by a panel of experts who will help us to bring together, summarise and reflect on our learning from the previous weeks. This session will also allow discussion around various cases submitted by the audience. So if you've got any unusual gels, scans or results that you think would be of interest and you would like to sort of present to send in for this session, then please submit them to Dina Patel at dpatel@imquas.org.uk, and that address is on screen right now. Please remember to sort of remove any patient identifiers from anything that you do send in. Now, this session is also open for registrations, and details of how to register can be found on the UK NEQAS website. Now, UK NEQAS is active on Twitter and LinkedIn, so if you do social media. I'd strongly encourage you to seek us out and follow us on these platforms, keep up to date with what we're doing. We've got a lot of things that are happening through UK NEQAS for immunology, immunochemistry and allergy, and lots of different activities that are also coming through the central UK NEQAS charity, reflecting the other areas of pathology that we provide EQA for. And finally, once we close this session, please do take a few moments to respond to the short feedback survey. Your views and opinions are valued, and we will use them to shape and improve our future events. So thank you once again to everybody that's taken part. I hope you're able to join us next week at the same time for our next webinar. Until then, take care and stay safe. Thank you.